Welcome to Lab Talk, where we break down the science behind clinical laboratory testing and make it actually interesting. I'm Amber, and today we're focusing on hemophilia, a hereditary bleeding disorder that highlights the vital role of the laboratory in diagnosis and management. Hemophilia is a sex-linked inherited bleeding disorder caused by a deficiency of either Factor VIII, known as Hemophilia A, or Factor IX, Hemophilia B. Because the genes for both factors are located on the X chromosome, the condition primarily affects males. Interestingly, up to one-third of hemophilia cases occur without a family history, arising from spontaneous genetic mutations. Hemophilia A is the most common, affecting about 1 in 5,000 live male births. Hemophilia B is less frequent, with a prevalence of roughly 1 in 30,000. Clinically and diagnostically, the two conditions are nearly identical, so laboratory testing is essential for differentiation. The hallmark symptom of hemophilia is recurrent bleeding episodes. Severity is closely tied to factor activity levels, and they are severe hemophilia, which has less than 1% activity and frequent spontaneous bleeds; moderate hemophilia, which has 1 to 5% activity and trauma-induced and occasional spontaneous bleeds; mild hemophilia, which has 5 to 30% activity and bleeding mainly after injury or surgery. In infants, signs may include profuse bleeding after circumcision, soft tissue hematomas, or excessive bruising once crawling begins. Untreated, recurrent joint bleeding, hemarthrosis, can lead to chronic arthritis and disability. This is where clinical laboratory scientists step in. In hemophilia patients, screening tests often show a prolonged activated partial thromboplastin time, aPTT, with a normal prothrombin time, PT. To investigate further, labs perform mixing studies to distinguish factor deficiency from inhibitors, and/or factor assays to identify whether factor VIII or IX is deficient. Because hemophilia A is more common, testing usually begins with a factor VIII assay, followed by factor IX if normal. These confirmatory tests directly guide physicians in treatment decisions. From a therapeutic standpoint, management relies on factor replacement therapy. Recombinant factor concentrates are preferred, as they lower transfusion-related risks. And plasma-derived concentrates or fresh frozen plasma may be used when recombinant products aren't available. The amount of replacement depends on bleed severity. For example, the goal is to achieve 30 to 50% factor levels for spontaneous bleeds, but 100% levels for surgery or trauma. Ideally, patients would receive regular prophylactic replacement to prevent complications, but this remains costly and inaccessible for many worldwide. To recap, hemophilia is a genetic bleeding disorder linked to factor VIII or IX deficiency. Severity depends on factor activity, influencing bleeding risk. The laboratory's role in diagnosis, through aPTT, mixing studies, and factor assays, is essential. Effective treatment relies on timely and accurate lab results, enabling physicians to deliver life-saving care. That's all for today's episode of Lab Talk. Remember, every coagulation panel, mixing study, and factor assay we perform has a direct impact on patient outcomes. As clinical laboratory scientists, we're not just testing samples, we're shaping lives. Thanks for joining me, and stay tuned for more episodes on how the lab can drive patient outcome.